and share?
No.
Okay. All right, I got it. I'll just turn it down and let you.
Okay. And then, okay. Well, and then I think you can like somehow hand over the to me being host. So then you don't have to stay on if you get off or however that works. But, okay. So objectively, we'll go through all the requirements for the rotation, and I'm recording this because I know there's sometimes that we'll have hub students. And first, if anything comes up at all, just like we've had the year of COVID, which knock on wood, hopefully we never have to encounter that again, and you guys can be in person on all of your rotations and have all the full experience. Contact wise, this is my email, this is Shandy's email and her cell. And anytime that you guys are going to send me an email, if you can always please go ahead and CC Shandy. She knows the answers to almost every question that you could probably ask. So she's also very much more readily available, can respond to things a lot quicker than I usually can. So it's just very smart for you to go ahead and do that. And a lot of the time when you don't CC Shandy, I end up having to CC Shandy anyway. So that would be your best bet. Let's keep going. Okay. So if you have a question, then first resource is probably going to be the syllabus. Most of the time, the answer is going to be in there. So please look through that. But if you have any questions at all, obviously let me know, let Shandy know, and we will get back with you on that. Perks of the rotation is that some of you will be in community settings. It's largely outpatient. We do, some of us are heavy inpatient, some more than others. Some of us do OB. I do OB. Some of us are procedurally heavy like me. But you can virtually travel almost anywhere with family medicine. You can go work on a cruise ship, go be in Alaska, work on resorts, do urgent cares if you want to, do lots of locums, or be stable with continuity patients. Lots of different options that you guys have. And that's one of the big perks that one of the huge reasons why I went to family medicine. For me, the other big key factor was that I was really able to treat the whole family. I originally thought I was going to do peds. I absolutely loved my son's pediatrician. I thought she was wonderful and loved that she was able to speak with me and really help me out. But I loved my internal medicine rotation, and it was, I liked the interaction that we had with them wanting to talk and tell me stories, and it was just very different. And I thought that might be something that I might want to do. I loved my surgery rotation, loved my psych. Can you guys hear me again? I just got kicked off. Okay. Let me try this again. Okay. So family medicine was going to hit all the things that I really wanted, give me lots of flexibility, lots of different things you can do fellowship wise. Sports, as you guys know, with Dr. Coleman, sleep medicine, you can do hospitalist medicine, palliative care. We have lots and lots of different options. Okay. So duty hours wise, it should be the same as on every rotation, 80 hours a week, no more than 80 hours a week, averaged over 4 weeks, and 1 day off in 7, and that you can't go over 24 hours continually. That should not be a problem whatsoever, not even close on family medicine. If you're getting close, then I need to know. So please let me know that. I know that sometimes we have people that are on the inpatient side for some stretches because we are short on preceptors. And then with the change in the curriculum that will be occurring, you guys will actually, well, so down the road, you guys will kind of see parts of it with the expansion of the class size. So preceptor wise, we're going to be putting people everywhere. You guys are pretty set with where you're at. So not really issues as far as that goes. But if you are with somebody at some point for some reason that also maybe does hospitalist, they maybe admit their own patients from clinic, goes over to see them. Again, probably not going to be over on duty hours, but please let me know. It's a huge issue if that occurs. Student abuse policy, I won't go through detail, but you can find the full policies on Leo under the course information. Obviously, there's zero tolerance for student abuse. And if there is anything at all that you guys feel like is inappropriate, should not be happening, or maybe even just like, maybe this was just weird, not necessarily wrong, but you've maybe felt uncomfortable, please let me know, because maybe this is something of a pattern that we need to know about. And, I have had students tell me that exact thing. Like, I know it wasn't technically anything wrong. It was just a little weird. And those kinds of things I like to know about, because I don't want you guys having anything weird or uncomfortable. I want you guys to have a really good experience and fully be able to see what a family medicine physician type of life can be. Okay, talked about the syllabus. Leo, you guys should be familiar with, most of you, I think, and Shandy maybe pulled it up for you guys, but this is where obviously that's the wrong year on there, but you're going to be going to the to your exact course. Everything, all the documents should be uploaded into Leo. Everything that I'll be referencing should be in Leo. You're going to be submitting everything through Leo. But if you have any issues with submitting things, which we do every once in a while, go ahead and just email it to Shandy, and then there'll be a timestamp on there. So we will know that you turned it in on time and that there was no issue with that. As long as you, if email it, then you're good. We can always upload it to Leo later. Just so you know, in case that occurs. Okay, so you'll go to materials. Everything should be there, basically organized by mostly by week. Today, because there's 2 different days within the week, there's the week 1 first day, and then there's a week 1 last day. So a little bit of a different organization style maybe than some of the other courses. You guys all turned in your personal goals already, which is fantastic. You guys all turned in your assignments for the Bob stuff, so that's fantastic. And we'll talk about some of that in a little bit. Evaluation wise, we have cut down quite a bit actually on the evaluations. There used to be an evaluation, many evaluations, but I know that you guys have plenty of other things to do, lots of studying that needs to happen. So I try to consolidate a lot of that for you guys for this year. So hopefully that will work out. The key things, because we reduce the number of evaluations that I ask on you guys, is that if there is an absolutely standout teacher, or in the other direction, somebody they're like, man, somebody needs to know that this was not good, please let me know. You can always just put it in an email if you wanted to. So you're like, I don't know if I'll remember to put this in the evaluation later. Or you can put it at the end. It's kind of a summative evaluation of the course. But if you can't remember the name of whoever it was, but you're like, whoever it was that taught this lecture did an excellent job, really loved it, or the opposite direction. Those 2 main things I really need to know. But what I was trying to cut out work-wise was just you guys having to fill in evaluations for just kind of run-of-the-mill things. That is, if it's kind of mediocre, okay, fine. but try to give you guys less busy work. With the procedures, the pet logs, this is something that comes through from the dean's office. So these are things that have to be done in one way or another. They have to be done by actually seeing them, talking about them, asking about them, or if you don't see it in clinic or at the hospital, then you have to do the alternate assignment, which does take some more time. You guys should be able to get all of these done. There should not be any issue in getting them done. Let me see if there's that. So these are the alternate assignments. It's toward in Leo. It's towards the end in the week 4, because obviously you want to give yourself time to find everything. But if push comes to shove, you have to do one of these. This is the alternate assignments. But if you guys look at, well, I thought I had, okay. If you guys look here, some people have asked me, okay, I didn't actually see anybody do a breast cancer screening, as in like they didn't do the exam or see anybody do the exam, then that it does not matter. It's if you even asked somebody, are you up to date on your mammogram? When was your last mammogram? You're still screening for breast cancer, right? That's assisting in breast cancer screening, making sure they're up to date on their screening. Because obviously, like if you guys look down, none of you are going to be doing anything with colon cancer screening, actively on family medicine. So again, that's asking, are they up to date? When was your last colonoscopy, Cologuard, whatever? Okay. Everybody with me so far? Okay. All right, mid goals. So with mid goals, that is obviously middle of the month. A very important time to keep track in your head. Make sure you find it on the calendar. You know exactly where it is, what we're looking for. That's a big day. It's the OSCEs, your EBM presentation, and your mid-goal feedback paper. That mid-goal feedback paper that Shandy gave you guys, there's another copy in Leo if you lose it, but that paper needs to be brought back to me, signed, completely filled out at that visit with me. So at the top of that paper, I highly recommend that you guys go ahead and discuss this question number 2 with your preceptor. Take it with you first day that you're going to be with your preceptor and say, hey, I really want to do well in this rotation. What are your expectations of me? How can I get a good evaluation from you? Okay, go over that, write it down in front of them, fill it out. That way it's fair and square. They've told you up front, this is what I want you to do. That way there's not issues later with them blasting you on your evaluation, end of course evaluation. But also I ask you guys to ask them for frequent, detailed feedback. A lot of preceptors, and I try to tell them I do a lecture for all of the preceptors as well. And I try to tell them, please give your students frequent and detailed, specific feedback. But whenever we're in the hustle and bustle of everything, it's really easy to say, oh yeah, you're doing great. There's nothing. And so it really kind of if you ask them, can you give me some specific feedback? Then it forces them to think, okay, I'm sorry, let me slow down a second and think about what you can do better. There's always something to improve on. So try using that verbiage. And then these boxes here are the boxes that you guys fill out. Sometimes you guys come in and bring them in their blank. So make sure that you fill them out. And then your preceptor will fill out these 2 boxes and sign. Okay. So make sure you bring that with you, your ABM assignment, and then your OSCE same day. And we'll talk more about those things. We already talked about verbiage you can use with your preceptor to get their expectations. This is your grade breakdown with your clinical performance and OSCE, your final. So your evaluations from clinic and your final are both 30%, both big chunks of your grade, 15% from your OSCE, and then you have this remainder of things. With 4, 5, and 6, if you just follow the directions, put your name on your paper, follow the directions. There's templates. We'll talk about this more in a little bit. Follow directions, use the template, then you will do great. Don't stress too much about those things, but we'll talk more. We round up from an 85.5 or above to an A. You have to get a 70% or better with each of these things so actually this is incorrect. For the final, it's a 60%. And we need to update that. It's a 60% because, and that should tell you guys something, because it is a difficult exam. If we had it at 70%, a lot more people would fail. At 60%, we still have people fail. So I'm sure you guys have heard the word on the streets that it's a tough exam. And I have gone over it. I've gone through it. There's some questions on there that are tough. So make sure that you're studying, and resource wise, I've tried to, I got feedback from students that did well, much better than a lot of the other students I had seen, given they were towards the end of the year, not exactly the last month, but the last quarter, I would say. So they did have knowledge built up from other rotations to help them, but probably some of the same resources you guys use all along and for other things. But I heard Dr. High Yield, AMBOSS, and UWorld were the resources that they used and did well with. I know we gave you guys that book, the case files book. Technically, every single question on the final can be found in that book. That book is very dense though, and it could be one little sentence on one page that you would have to read to know how to answer that question. There is also a study guide in Leo. I did not create that study guide. I will preface that. I don't feel like it is much of a study guide. The person that made the study guide has come to admit that they don't think it's very helpful. So I don't know that I would waste a whole lot of time on it, except that I would maybe just glance through the words and make sure that you're familiar with all of the words. Because on the study guide, you know, if there's a word on there that you don't recognize, it may help you to eliminate one of the answers on the test. So just make sure that you are familiar with all of the words on there. Otherwise, I wouldn't use it too much more than that. So to complete the course, you have to do the patient logs, you have to complete the course evaluation. And then with unprofessional behavior, that is grounds for failing the entire course. Luckily, I don't have too much trouble with this, but we have had instances. So biggest thing, show up for your rotation, show up for your rotation, show up for your rotation. We give out the calendars to the preceptors so that they know when to expect you there. I have my secretary, assistant, put the calendar into my phone so that I know who's supposed to be there and if they're not there. And I tell the preceptors, I need to know immediately if my student is not there with you. I need to know. And I take it very seriously because it's led to us finding some pretty big deals. I mean, with like mental illness, depression, drug use, suicide is another thing. I have not had that here. So, and I never want to ever have to encounter that, but if you guys, and this is why, if you guys don't show up to your rotation, the preceptor is informed to tell me immediately. If you don't answer your phone and I try to call you, I will send the cops out to your house to come and check on you, not to punish you, but to come and check on you. Okay. It's a big deal. So please go. If you are needing to miss for whatever reason, we do need to know ahead of time so that we can clear it through the dean's office. But please let us know. But easiest thing to do is just show up for your rotation. If you're having any issues, if you are struggling with any mental illness, again, that's something else that you can definitely tell me, or you can talk to Dr. Scordino about, and we will definitely do what we can to help you. Okay. We talked about that. For the shelf exam, we talked about this, but it is 100 questions. You get 2.5 hours. It's a raw score of 60 out of 100 questions. And you'll need to have your computers to take the test. Shania will give you guys more information about that when it's closer. There are board review questions available. I have heard that these questions are a little bit higher level than what you guys are really capable of answering at this point. So they're not super helpful for the shelf itself. That's what I heard. So take that with want. For the longitudinal case, that's your Bob case that you guys looked at, and we'll talk about that after we get done with this orientation. Quizzes, there is a quiz that happens with every didactic session, but they're not for a grade. They're for you guys, for your self-learning. I highly recommend that you look at them ahead of time. We actually even the questions and the answers are both posted in Leo. So it's purely for you to see if you can answer the questions. Every person that does a lecture might be a little bit different. Some of them might go very slowly through the Bob and very slowly through the quiz. Some people might say, do you have any questions about the Bob, or do you have any questions about the quiz? And if you don't, then just kind of keep moving forward. But either way, go look through them, make sure that you're prepared. And so that way, if you do have any questions, you don't understand a concept, then that's a great time to ask whoever's teaching to explain. This talks about like group quizzes, individual quiz. We don't really do that anymore, but you might have somebody that tries to break you up into groups to do the quiz and then do it individually, but it's all the same thing. And then week 4 is dermatology, and there's a game that happens that day. We don't do that. So with the Bob, you'll have one that you guys turn in. It's a patient that you guys kind of follow throughout the course of the month and kind of build on concepts. So again, not every lecture might go into as much detail. You guys turn in the assignment beforehand, so usually you'll probably understand and have things down pretty well. But if you want the lecturer to go into more detail, always ask. Feel free to ask. The EBM assignment, that is the one that you guys are going to be presenting to me. Sorry. Okay, that you guys are going to be presenting to me during that same day as your OSCE. There, like I said, there is a template that you'll follow. Biggest things to make sure of for that is making sure that your article is within the time frame that it says. It says it on there, but sometimes people still don't follow the rules with that. It has to be within the last 5 years that it was published. If it's not within the past 5 years, I have to dock you points because that is part of the grading rubric. Okay, so don't lose points with that. Whenever you do your presentation for me, it's not anything like crazy. You don't have to make a PowerPoint. I get asked that question as well. You can use the paper that you type up to present off of, so you don't have to memorize it. So I don't want you guys spending like days and days and days and days on this. I would much rather you guys be using your time to study. But this, for one, is a good learning point, but secondly, it's a requirement through the dean's office that you guys do evidence-based medicine. So it's not something that we can just get rid of. I've had that complaint as well. But I do enjoy listening to your guys' presentations. I do learn things from you guys. But please don't just read off of your paper to me. It does get a little bit boring. And I can tell if you're familiar with it or not, or if you're just purely reading. Like obviously I can read. If I wanted to just read them and grade them, then I could do that. But this is also a presentation grade. So I would prefer for you to just reference the paper other than just read off of your paper. That way you're also more likely to be able to answer any questions that I might have. Being able to answer my questions is part of your grade. You can have the article there that you are, or articles that you used for your paper. You can have that available as well, and be just kind of familiar with it. If you don't know the answer off the top of your head, that's fine. You can look for it. But I can tell if you just didn't put any effort into it. Or I had one student that very much completely just read off the paper and then didn't know any answers to my questions and then said, yeah, I did this a long time ago and I haven't looked at it since. And so, okay, I can kind of tell. So don't spend a lot of time, but be familiar. That's the gist of it. And then you will do great. Okay. Any questions on that? Okay. For your clinic note, again, follow the directions and you will do great. Just remember to put your name on the assignment. It never fails that I have people that don't put their name on it. And it makes it a little bit difficult if there's more than one of you that don't put your name on it. So there's a template, follow the template. The biggest thing that people get counted points off of is not putting the chief complaint in the patient's own words. I'm going to stress that again, in the patient's own words. So don't reword it into technical terms. If they say things with bad grammar, fine, put it with the bad grammar, put it in quotes. I don't know why people continue to do that. But that's really the biggest area, and it's super easy, but put it in the patient's own words. The chief complaint in the patient's own words. That's what it means by the undifferentiated complaint. Secondly, be looking for a patient to do the clinic note on. It's a full history physical that you're typing up, like the best SOAP note you've ever written type thing. Be looking for opportunities to do that. I ask my preceptors to let you type into the chart or type on a computer, if it's your computer, even if it's just on a Word document and then you erase it every time. I want you guys switching over away from your pen and paper to typing on the computer, even when you go into the room to just see a patient and present to your preceptor. Practice the typing. One, because you'll be halfway done with this assignment if it's one that you can use for it and you kind of went into depth, right? Because you'll probably at some point have an established care that you're going to be asking all the questions. Even if it's not an established care, you can ask your preceptor, hey, is this one that I can go ahead and do the full history and physical? Or because I know that there's most places we're still running very quickly. patients every 15 minutes. And that's including the nurse doing the vital signs and rooming the patient. So by the time we get in there, we have like 5 minutes. So if you don't ever get to do a full history yourself, you can still look up the information in the patient's chart. I've been asked that as well. So I don't want you guys to feel like you can't do a note because you didn't get to ask all the questions yourself. That's not a requirement. It'd be great if you could, because then you've already typed out everything, but it is not a requirement. Next, try to be a little bit picky about the patient that you choose. Doesn't have to be anything crazy, but I had a student turn in a paper that it said past medical history unable to obtain, surgical history unable to obtain, social history unable to obtain. And then it says that the plan sent patient immediately to the ER for chest pain. And I was like, okay, probably not the best patient to choose, but still, again, you could have looked up the information in EMR. So please don't do that. Please don't do that. Any questions about that assignment? All right, for the OSCE, we're going to talk about this for a little bit too. So same day as mid-goal feedback, OSCE, EBM presentation, okay? For the OSCE, and this is, again, this is why I say to go ahead and practice the typing. For our OSCE, we have you guys, it's 15 minutes for you guys to do your information gathering. That is much quicker. That's a lot less time than you get on other rotations. You may or may not have had one already, but it's not a lot of time. A lot of students feel rushed, and it's a very real life scenario. So we are not wanting to change it. And we actually used to have, I don't think you guys, I think they stopped them quite a while ago, but a very big series of OSCEs, like a huge OSCE final, basically, that I flew to Philly to go take mine. And it was 15 minutes visits back to back to back to back. So we want to keep it that way, but it is not a lot of time. So you do need to know what you're doing. You do need to prepare for what you're going into. So let me just kind of break this down so that you don't make a mistake that has been made in the past. So there's 2 OSCEs, right, that you're going to be doing. One is an MSK, and you'll use the skills that you guys talked about this morning. I highly recommend practicing those on a friend, family member, whatever you can. Second is the counseling OSCE. For both OSCEs, you're going to do the entire history, meaning the past medical, the social, all of that, okay, for both OSCEs. For the MSK, you're going to do a physical exam. That's kind of one of the big reasons you're doing it. So you're going to do the physical exam. For the counseling, you do not do a physical exam. If you try to do a physical exam, the SP is told to stop you so that you don't waste your time, okay? For the MSK, you're going to do all of that, do the history, do the physical, come out at the 15-minute mark, type your note. That note comes to me and I grade your note. What happens in the room is what the SP grades. For the counseling session, you're going to use your 15 minutes, gather all the history, and you're going to also do your counseling within that session, okay? When you leave, you're not typing a note for that. You actually, you're giving the SP a little bit of time to gather their thoughts to give you feedback. So during the time that other people are typing their MSK notes, you go back into the room and you get your feedback from the SP, okay? For the MSK and for the counseling, there is, if you go into Leo, there is a document that I condensed. There used to be like 5 different documents in different formats. There is one document that I've condensed down for you that is very helpful. Make sure you look at it. But it has the differential for the things that you like, the answers, basically, like we're giving you guys the answers for what the scenarios could be for MSK and what the scenarios could be for counseling. So make sure that you look at those. I have had students, never fails, their number one answer is something that's not even on the list. So it definitely, if you don't know, just at least pick something that's on the list. But you're going to be putting multiple differential diagnoses, and one of them should be a can't miss diagnosis. Okay. The thing that students very, where they lose the most points potentially for the MSK is not writing in the note, not writing your reasoning. So make sure you put pluses and minuses, or it's this because of this, or I think it's this because of this, or I thought it could be this, but they didn't have this. Any kind of reasoning, some type of reasoning. Okay, put a little bit of a physical exam and put your differential, put your reasoning. Okay, if you don't put your reasoning in there, it drops you down quite a bit. So please make sure to include that. For the counseling session, when they come in and talk to you, make sure, again, you're getting the entire history. We've had somebody that lost a ton of points because they came in, stated what their chief complaint was, and the student just automatically started counseling them instead of getting all the information. Okay, remember, both cases, you're gathering history, the full history. It's a full but focused. I'm going to clarify that, right? You don't have time like back in Clin Med to ask every single thing off the list, but so focused but full with every category. So you want to be thinking ahead of time. Okay, if they say that they're coming in because of somebody told them they had high blood pressure, or somebody came in because of obesity or because of smoking, make sure that you know what things you're going to hit beforehand. Family history is one that people lose points on, because you need to probably specifically ask them about if they have family history of such and such. Like, do you have people in your family that are obese? Do you have people in your family that have, if they're a smoker, do you have people in your family that have any lung disease? Okay, it's that right there is not as probably counterintuitive. Is not intuitive. So make sure that you are asking those questions. People will ask family history in general, but not those specifics, and then you lose those points. Does that make sense? Okay. So when they come in for whatever they're doing, it's like they're coming in, they're not very happy about the situation, or they were forced to come in for whatever reason, or their wife said they're fat or whatever. So they coming in to see you. So you want to make sure that you are not trying to make them feel judged. Make sure that they feel welcome and that they made a decision by coming in. You're happy that they're there. You're going to work together. You're going to come up with a plan, and then you're going to check you're going to have a good closure. Okay. In both scenarios, make sure that you have time to have a good closing. With both scenarios, you're going to say, okay, I think that you have this. The next steps would be this. You're going to rest, or we're going to get this imaging, or we're going to send you to surgery, or whatever. But make sure that you allow yourself to have good closure, and that you can assess the patient's understanding of what's going on, right? And so what somebody tell me, what is the best method of assessing a patient's understanding of of your visit?
Teach back method.
Very good. Very good. Yes. If you do that, you'll check all the boxes. You'll know that they understand. They'll know that you know that they understand. It fits everything. So make sure that you do that. You're coming up with a plan together, and trying to help them work towards a better lifestyle or meet their goals or whatever that might be. Okay. Let's see, what else can I say about the OSCE? I think that's it. There is on that document that I mentioned for the OSCE, there is a link for a YouTube video that it's me talking again with almost everything that I'm saying right now, in case you need to rehash any of it. I think what I'm saying right now is a little bit more detailed than what's in that link. But that link is there and is available to kind of talk through the two cases. Okay. Any questions? No. Okay.
I had a question. Sorry.
Yes.
So are we allowed to, or is there a way for us to, like, because some of us are coming off selectives and haven't had a core clerkship just yet. So I was wondering if we are able to go to the CSET and maybe like go practice a 15-minute OSCE or anything like that, just to refresh.
Good question. I know that we used to do that in the past. With COVID, I know that changed a lot of things. I'm not sure if they've restarted that or not. That's a really good question. Kayla Pullen and Ton, are you guys familiar with the two of them over at the CACTC? I don't know if you've gotten emails from them before.
Yeah, I think we are.
Okay.
Yeah.
Okay. So if Shandy, are you on the line still?
Yes, ma'am.
Okay, could you ask that question about if they are able, I know they used to allow them to, they'd have to schedule it ahead of time because they'd have to call an SP and say, hey, are you available to come in for whatever time to practice with the student? I don't know if they're doing that again or not, but can you find out for us and let the class know?
So see if they can set up a practice OSCEs, basically.
Yeah, like yes, like not necessarily the same. I don't know that they'll do like the same scenarios, but somehow like go in and practice, yeah, with the SPs. I know they used to do it in the past, so Kayla's probably knows what we're talking about. But but
Okay,
yeah,
I'll ask
like
her and I'll let you guys know.
yes. Okay, thank you.
Uh-huh.
Okay. Any other questions? Okay. So for the interprofessionalism assignment, this is a pretty easy thing to do. Again, this is a dean's office requirement that we have to do some type of interprofessionalism activity that's graded. So what we have with this, be kind of thinking from the beginning about a patient that might be good for this. You're basically going to try to think of a patient that's very complex or has at least some complexity to them, where they are needing physical therapy or multiple specialists or home health, anything like that you're helping to arrange or coordinate, or you have to go and talk to the social worker, but kind of patients that have to overcome barriers, and how you maybe helped them overcome barriers, or how your preceptor helped them to overcome barriers. Did they have trouble with transportation? And you tried to help them with Sooner Ride, or did they need resources about free dental clinics or counseling services, anything like that? Okay, then you'll write up this paper. If you follow the instructions, put your name on it, you will do well. Okay. So there should not be a session evaluation for today. It should just be the one at the end. And that should be it for that. Okay. Do you guys have any other questions in general? Okay. I'm going to talk a little bit through the Bob case. I'm probably not going to go through the quiz questions unless you guys have any questions specifically about those. And if you didn't get to look at them ahead of time, that's okay. You can tell me, and I can give you a second to look through them. But does anybody have any questions about the quiz questions? Does anybody need time to look at them real quick? Okay. If you look at them and you don't understand something, let me know. But let me pull up. Okay, I'm going to pull up the Bob case. And if you guys can pull up the Bob case as well, so we can kind of look at it real quickly. And since you've already turned in your answers, you guys probably will be on the ball and be able to go through this. But sometimes I like to try to challenge you guys to think a little bit in different ways. So, but I might not have anything else to teach you guys about it. So we'll see. All right. So Bob is a 41-year-old male who presents to you in a same-day appointment slot with back pain. He was playing softball over the weekend and noted back pain after sliding into third. Bob is a new patient to your clinic. He has 3 children that are all school-aged. He's married to his second wife and mother of all 3 children. His first marriage was annulled and he stated it was a teenage mistake. Bob lays tile mostly in new construction, both residential and commercial. He graduated high school and had some vocational training. Your history reveals that Bob injured himself 3 days ago. Pain was worse on day 2 when he arose. Pain then with a 10 out of 10. Now it's an 8 out of 10. He describes the pain as stabbing in his low right back and side. He notes bruising over the area. He took some ibuprofen for the pain, 6 of the over-the-counter pills 3 or 4 times a day over the past couple days. That usually takes the pain down to a 7 out of 10. He notes lying on that side, reaching or carrying towel makes the pain worse. Pain gets worse as the day goes on. He hopes you're going to give him some strong medicine to help with his pain. It hurts when he takes a deep breath, coughs, or laughs. He denies fever, bleeding, numbness, or tingling in his legs. On exam, you know, body odor and what looks like tile dust on his clothes. Blood pressure is 145/78, weights 215, height 5'10", pulse 85, and temp 98.6. With his back on an inspection, it's normal on the left, and he has ecchymosis on the right flank. For palpation, he is tender on the right side to palpation. On the left, he is non-tender. He has no masses bilaterally. Range of motion for his back, he has normal flexion, decreased extension, decreased right lateral flexion, decreased rotation, left and right, pain on the left lateral flexion. Neurovascular, he has normal sensation, normal inguinal, popliteal, posterior tibial pulses, 2+ reflexes, patellar, and Achilles bilaterally. Special tests are negative for the bilateral straight leg test. Okay, so what is your group's diagnosis and plan for Bob? And the faster we talk, the faster you guys can get back to whatever you need to do. So talk to me. If you're wrong, it's fine.
I think it's probably musculoskeletal pain, just given
Sure.
his range of motion stuff, and yeah,
it definitely could be musculoskeletal. That's a very good differential. Yes. What else?
I think not likely, but it could be renal calculi or herniated disc, since it's in the same region.
Very good. Yes. Very good. Absolutely. Those are other things that we have to think about as well. What else?
I think similar to what Ben said, some kind of spinal nerve root compression, just from the impact.
Sure. Yeah. What else should we be thinking about? You guys are doing great, but I'm just trying to make you think. There's a couple of things that I want you guys to think about.
I mean, you could be having some kidney injury. You
Yeah.
could see, you could try to see it on a urinalysis, see if there's blood in the urine.
Yeah. Very good.
I think
Okay.
like probably not likely, but a aortic dissection or some type of, AAA or something like that.
Yeah, absolutely. Absolutely. But again, like you said, probably not likely, but definitely something that we need to be thinking about with the pain that the type of pain that he's having, for sure. Very good. Okay. What about it talking about that it hurts when he takes a deep breath, coughs, or laughs?
Maybe like something with his gallbladder.
Possibly. Yeah. Gallbladder pain can do some of that. Yes. There's a lot of referred pain with gallbladder stuff. Absolutely. What would be a little bit more common? Sorry for the outside noise. I apologize.
Maybe a lower rib fracture.
Yeah. So that's something else to think about as well. Okay. So he could have more than one thing going on. That's something else that we kind of have to think about in medicine, that sometimes we all like try to go and focus in on one thing and forget that people don't follow the textbooks, right? They don't read the textbooks. So they can have more than one thing going on, kind of blurring the picture. Okay. So what do you want to do for Bob?
Definitely get an X-ray of the area.
What area?
Say the pelvic girdle.
Okay. Pelvic girdle.
So
Also
that-
spine.
The what?
Spine as well.
Okay. So whenever you put in an order for a spine, it doesn't usually just let you order spine. You have to be a little bit more specific. So what area would you order?
Lumbosacral.
Lumbar. Good. Very good. So yeah, so I think that's a great option. If you guys are wanting to roll out things like a disc herniation, right? Okay. What else should we do?
I'm not sure if we should just directly get a CT. I was just a little concerned about the ecchymosis, so I don't know if like that's like a first line eval that we should go
Yeah.
for.
So on that note, what can the ecchymosis potentially mean? And it doesn't have to be you that answers. Anybody can chime in, but what does ecchymosis? What do we have to think about?
Probably a soft tissue bleed or something locally.
Yeah, could be soft tissue bleed. We could have some type of internal bleeding, but with it being 3 days ago, he's pretty stable, right? His blood pressure, pulse all look good. So is he internally bleeding? Probably not, right? But a CT potentially we could. Insurance does not like us to, we have to have very good reasoning whenever we're ordering things, right? And CT would not be unreasonable, but they would want us to start with an X-ray typically. An X-ray alone for this guy could show us a pretty good amount of things. What information? So this kind of brings up another good point. Whenever you're doing your review of systems, and I talk about this with my ClinMed kiddos, but I like kiddos, I'm sorry. students, with my Clin Med people, I talk about when you're doing your review of systems, pertinent positives and pertinent negatives are both very important, right? Sometimes the pertinent negatives are even more important than the positives. In this guy, what would be some pertinent negatives that you guys should be asking about and should be included in a case like this?
The normal sensation and reflexes can
Very
help.
good.
Yeah, and
Very
feel
good.
straight like dust.
Yeah. So so normal sensation, where exactly? Or denies what?
Like above the L4 where the patellar reflex would be. So is that what you were getting
Okay.
at? Sorry.
Yeah. No, it's okay. So yeah, so if there was anything abnormal with that, that would be a concern for sure. But what would I need to say, hey, you need to go to the ER, like we need to go to the ER right now? If
If
he
they're having
admitted
like
to some,
saddle paresthesia.
yes, exactly. That's what I was looking for. Yes. So that should be, it is normal sensation. Did they ask that specifically? I don't know. So that would be something that I personally would want you guys to report to me or personally write down, right? Because we gotta know that this is not a big bad thing that we gotta take up immediately. Okay. All right. So what else do we need to do for Bob?
Avoid any kind of strenuous activities that could exacerbate the pain, but continuing to move and not being inactive for a prolonged period of time, I think would be good. And
So-
considering his job, he has to move quite a bit for his job, so considering that.
Right. So what do we need to do for him specifically? Probably.
We need to do some kind of pain control for him, or I don't know.
You're right. You're right. We do need to do some pain control. So we'll hold that thought
Like a worker
about the limiting activity. Sorry.
Like a worker's, like a note for him, for his
Yes.
boss.
Yeah. He's probably gonna have to have some type of a letter saying, hey, he's gonna have to be off for a little bit of time, or is there something else that he can do with that line of work? There's probably not light duty work that he can do, maybe, I don't know. But that is something for sure that you guys will have to take into consideration. Now, with that, with people that do this type of work, I mean, they are doing that type of a job for a reason, most of the time. Obviously there's all kinds of different people from all types of different dynamics that do this, but a lot of the time they are living paycheck to paycheck, right? And they need that work. So you might have a little bit of a fight from them saying, yeah, I can't do that. How much time do you guys think he would need off? Ideally.
Like 4 to 6 weeks.
I mean, so if it's somebody living paycheck to paycheck, are they going to be able to take 6 weeks off of work? Probably not, right? So you might have to get a little bit creative with them, kind of do some negotiating to try to figure out something. Some of them you might offer to fill out FMLA paperwork if there's anything like that they can get through their work. Sometimes they can get some type of compensation while they're having to recover. But just make sure that you're thinking about all those things for your patients. Okay. All right. So back now to the pain control situation. What do you want to do for him?
I think he's probably taking too much ibuprofen at the moment. I don't know the dosage specifically.
Good. If it's over the counter, it's probably 200 milligram. If he's taking 6 of them, that's a lot. You guys probably know, like, the prescription dosing we give is usually like the 800, right? So he's taking a lot. And he's doing that multiple times a day, right? Okay. So we've established that he's taking too much ibuprofen. So what do we want to do for him?
Switch him to something else and stop the ibuprofen, or
Yeah.
increase it.
Yeah, or decrease it. Yeah. So I have a lot of students that say, well, he needs to decrease the ibuprofen. I'm like, okay, great. But if he's in that much pain, you can't just tell him to stop or decrease one thing and not give him something else. So good job saying that we need to give him something else. What do you guys have in mind?
I mean, if the cause of his pain from the CT comes out to be neuropathic by any chance, he could be started on gabapentin or something like that.
Gabapentin, if we think it's neuropathic. Yeah. Yeah, absolutely. That is a great thought. That's something that a lot of my residents even don't think about doing. So very good thought. Let's say that he's not really having any nerve type stuff.
Injection, steroid injection.
Steroid injection. Yeah, that you could do an injection, or you could do oral. There's a little bit of a placebo effect with the injection. But you can do the same with giving them oral steroids for 5 days. It's like a steroid burst situation. Very good, because that will help with that inflammation, right? Okay, what else? What's something else that we can do?
Like a muscle relaxant.
Yeah, you can do a muscle relaxer. That's something that for some people they may or may not have been exposed to. So kind of ask if it's something that makes them sleepy or not, or warn them that it can make them sleepy, or to maybe just try half of a pill at first and see what that does, or try taking it just at nighttime. Okay, good. What else?
Maybe just reducing ibuprofen and adding acetaminophen instead.
Yeah, very good. A lot of people forget about acetaminophen. They're like, oh, it's just Tylenol. Like, I don't want to just adjust that because it's just Tylenol, but it's Tylenol, and Tylenol is actually a really good pain reliever, fever reducer, and controlled medications, opiates, a lot of them have Tylenol in them, right? So they're not putting it in there for no reason. They're not going to just waste their money and add it to their pill. It does help. It can help. So very good. What else?
On neuro, we gave somebody the caspacin or whatever cream.
Mm-hmm.
I don't know if that's something that you can, implement to
Sure.
with this patient.
Yeah, absolutely. Absolutely. That's okay. Within that the lumbosacral region, if he's having some pain there, you can do that. Very good.
If
What
it
else?
happens to be like a muscular issue, there could be some PT exercises you could start doing.
Yeah, very good. That's another good recommendation. I like it. One thing to keep in mind with PT is, depending on their insurance, that it can be expensive. So sometimes something that we have to do in our setting is providing them with the exercises, or say, hey, just go maybe like one time to the outpatient PT person and let them give you some let them do a really good full analysis and give you some exercises to work on, and kind of get a big bang for your buck with that. But it's usually like $30 a session. And going doctors will recommend going twice a week for 6 weeks or 8 weeks. And that's a lot of money for a lot of people. So, so just, yeah, keep that in mind, but very good. What else?
Ice or warm compresses.
Yep. Ice or warm compresses. And that's exactly what I say, whatever makes it feel better. Some people ask, do I do ice or do I do warm? Like whichever one feels better. Okay. What else? You guys are my conservative group. What have we not talked about?
Like strong
Opioids.
pain meds, yeah.
Yes. Okay. I know everybody's avoiding it. And I tell you, yeah, I'm not a huge fan of handing it out either. But would it be reasonable to give to this patient? It could be, right? What do I need to do before I give him a prescription?
Need to like at least attempt reducing the pain with less potentially harmful drugs, I guess.
Sure. Yeah. That's a very reasonable answer. Yes. Let's say that he's like, I really need something. I can't. And he's giving you all the things, and you're saying, sure, I'm gonna go ahead and give you something. What would you? Let's say that there's good reasoning. You've established, okay, yes, he needs it. What do I need to do?
Well, I think one thing would be talking about the goals of the pain management at that point, because I know we had a lecture way back when talking about the goal. Like, I think when you get into opioids is less to eliminate pain, more to just make it manageable with other things. So that way he doesn't get into taking several pills, getting really stuck on it, to thinking he needs to be completely without pain. It's just to make it to where he can operate okay.
Absolutely. That's a very good point. It's to make the pain more manageable in conjunction with other modalities, right? So if I give somebody pain medication, it's I just had to have this conversation just yesterday with a residence patient that they wanted the pain medicine and nothing else, right? And they actually have to promise that they are going to agree to do the other modalities of pain management. And so sometimes we have to remind them of that. So one of the things that they have to do before I give them these payments is have a conversation about that. Okay. So there's lots of rules with prescribing pain meds, right? What are some things I have to do before I can give him a prescription?
I don't know if you have to do this, but aren't you supposed to check the database to see if they have an outstanding prescription?
Yes, you do. Legally, actually, you do have to. And they track it. So if you don't do it and they see that you're never checking the PNP on everybody, you can have your license revoked. So very good. That is something that we have to do. So let's say I checked his PNP and he hadn't had anything in the past year, and we checked, we looked at it's looking at all the pharmacies, and we checked Nebraska and Texas and Kansas, and there was nothing. Okay. And so I'm like, okay, we'll give you some. What else do I have to do?
Could
Yeah,
you,
Sorry, go ahead.
any history of previous drug abuse, not just opioids? And his history.
like ask a look in the history. Yeah, you could look for that. Yeah, you could look for that. I don't have to do that, and I don't have to ask him that. Could you? Sure. But you also don't want to punish a patient for having that history and withholding something because of that, right? It is an interesting conversation to have with them, where more often than not, really, once patients have kind of gotten past that phase, they'll say, I actually used to be addicted. I had a problem with it. I would really like to avoid it if I can. So I mean, and it's a conversation to have, and a conversation even before we give them prescriptions, that it is a potentially addictive medication. It's only fair to warn people that it could happen. Okay, so what else? Good thought.
You have to ask if they have ever had any adverse reactions to it.
Yes, make sure they don't have an allergy. Good. And you should do that with all of our medicines, right? Okay, what else?
Make sure they have naloxone.
Yes. So legally, I don't have to give it to them unless they're over a certain morphine equivalent amount, but giving it to anybody and everybody is actually great. I literally have some in my backpack right now for if I ever come across anybody that might haven't been overdosed, right? And we actually have them in our clinic available. All you have to do is, any of you really, if you wanted to carry one around with you, you could. There's just a little paper to sign and say, yep, I'm taking one. Basically, they're just trying to keep track of it so that they know how many we're giving out. We're trying to, it's a big promotional thing that we're wanting to give them out to lots of people. My Zoom might shut off again. It's saying the internet's unstable, just FYI. But yes, so you don't have to unless they're over a certain morphine equivalent. And actually, like, the pharmacy will a lot of times say, hey, this person, if they're good pharmacists, they'll say, hey, can you please put in an naloxone for this patient? And it's a nasal, the one that we have. I think there's another form, but we usually, a lot of time, we put the nasal, right? And it's a pretty, we've given it inpatient multiple times. That's the only time I've done it, but it's a pretty crazy reaction. If you've never seen it before, you can Google it. Okay, good. Very good thought. What else? So probably not for him that I have to, because he's naive to it, right? But giving him one would be a great idea. And not because I think he's probably going to overdose on it, but it is also for safety, that we're like, if we tell them to make sure that it's safe and locked and not accessible to other people to be stolen, or, you know, with like kids or grandkids around. But that's another reason where, like, sometimes my patients might be hesitant, but I'm not an addict, I'm not going to overdose, I don't need the naloxone. I'm like, well, you need to be thinking about, like, your dog, your grandchildren, anybody that it's a good thing to have it. Okay. What else? This is something else that I have to do.
We talked about checking the registry for their previous prescriptions. We have to add them to the registry when we prescribe it.
Yeah, yes, you do have to check and to make sure that they have not filled recently or they're not lying to you. Okay, think what kind of order would I need to place for him?
Do you have to like counsel for like work, drive, like, cause you can't, you have restrictions when you're on the medicines.
Mhm.
I don't know if I don't think you can drive or anything like that, so.
Right, you're supposed to counsel them to not operate any heavy machinery, and then, yeah, some of their jobs themselves might have their own legal restrictions and say you cannot be on anything at all if you're going to be working here. It's a little bit of a gray area from our end, except for like heavy machinery.
Would you need a drug test?
Yes. Yes, you need to do a drug test, because as much as I want to believe somebody that they are not, because if I check the PMP and he's completely clean, you know, I want to believe that, but then I'm like, oh, you have opiates in your system. Great. So I am not going to be giving you any because you're getting them illegally, which is unfortunate and sad, but like I can't, I cannot. He's considered high risk at that point. And so I cannot. If he absolutely has to have something, I could send him to pain management for help. Which I know, like, it's a sad situation because he's probably just going to continue to get them off the street. But that is something that we have to do. Okay, good. So let's say I'm going to give him some Norco 10 for some time. How many can I give him?
Is it just 30-day supplies? Is like the
That's
max?
that is a good guess. So this is his first prescription. So there's a different rule on the max, actually. Does anybody know? 30 days normally, yes.
So maybe
That's
60 or 90?
It's so for 7 days, that's all I can give him is 7 days worth for his first prescription. So let's say I gave him 7 days worth, he comes back 5 days later and he's doing okay, but he's like a little bit better. But he's been taking the Norcos. You do a drug test, he has it in his system, you do a pill count, he has the exact right number of pills. You decide, okay, I'm gonna go ahead and give you some more. How many can I give him?
30.
So it's 7 again.
Oh.
Good job trying though. So the first 2 prescriptions, you're only allowed to give them 7. For the third one, at that point, it is considered a chronic pain prescription at that point. And so then I have to do a pain contract with him. We have to go through and talk about all those things that you guys mentioned. We should have already talked through these things, but this is a legal document that we are signing together that we go through and say, these are all the risks of you being on the medicine. This is you agreeing that you're going to do anything else that I recommend that you do, like physical therapy, or we're going to try, gabapentin or the tricyclic antidepressants, or, a number of different things. And that they're not allowed to share it. If they lose it or it's stolen, it doesn't matter. I cannot give them an early prescription. If they get it filled with somebody else, and then they're avoiding their contract with me. So lots and lots and lots and lots of rules with that. Even if I don't plan on doing it for a year, like for him, hopefully we're just getting him through a short little period of time, right? But I still legally have to do a paying contract with him, okay? Let's back up and say that I pulled up his PMP and, so we're back to the beginning. I haven't given him a prescription yet, but I pulled up his PMP, and 4 months ago, he had a like a 10-day, or sorry, we'll say 7. He had a 7-day prescription for something, and then like 10 months ago he had another like 10-day prescription, or sorry, 7. I'm still on old times. 7-day prescription for something. How many could I give him today? And I know you guys are just guessing, so it's okay if you're wrong, it's fine.
Would it be 0? Since you're assuming he would have a contract with those other people.
So good guess. So, okay. So let's say, so if he had 7 with somebody, he had 7 with somebody. He's only had 2 prescriptions in the last 12 months, if we're looking at that, right? I don't know just by looking at it what the prescription was for, but that does actually matter. Who wrote it does not matter. What it was for does matter. If he let's say it's a different patient, a completely different patient with chronic knee pain, and 10 months ago got a prescription for his knee pain, 4 months ago got prescription for his knee pain, here again with me for a prescription of knee pain, at that point, because it's the 3rd prescription for the same complaint, I have to do a contract with him. If it was 10 months ago, he hurt his arm playing softball, and then 4 months ago he hurt his knee playing softball, and this time it's because he hurt his back playing softball, I don't technically have to do a pain contract. This is kind of, we're starting at baseline for that injury. But so it doesn't matter who the provider was. And when you pull up the PMP, it shows you all of the different providers. So yeah, you have to ask the patient, if you're seeing them get multiple prescriptions, you have to ask them what they were for. Okay, does that make sense? Okay, it's a little bit tricky. It's not, it's a little detailed, I guess. But that started, I think, 2 Novembers ago, I want to say. So it hasn't been a rule for super long, but something that you guys just need to know about and be aware of. Because at some point you're probably going to be providing some type of a pain prescription, even, in peds, wherever, whatever specialty you do, some more than others, but okay. Let me see, what else do I have for you guys? Let me go back to Shandy. Okay. Okay. So I think that's really the gist of all that. I don't think I have anything else on here. I think you guys have gone through everything. Trying to think if there's anything else. I don't think so. Do you guys have any other questions about that case at all? Hopefully you learned a little bit. I know you guys probably spent some time trying to answer that, but that's one reason why I do go through that case, is to get you thinking a little bit more, maybe about things that you weren't thinking of beforehand. And thank you guys for being interactive and answering questions and being interested. So if you have anything else, any other questions along the way, please let me know. Please reach out to me /Shandy and we can help you out. Let me know for anything at all. You guys have a good rest of the day, rest of the evening. And I'm sorry that this was delayed, but I appreciate you guys. And now I have a recording of this. So if you guys do need need to come back and look at the recording, we'll have it available. If you do want that, we'll figure out a way to have that available for you guys. If you want it, we can do that for you. I did it for future classes, but you guys are more than welcome to have access to it as well. Okay, thank you guys. I will talk to you later.
Thank you, Dr. Jones.
You're welcome.